Our first webinar today, the role for the EHR in patient safety. What does the evidence tell us? We'd like to cover a few brief housekeeping issues before we start today's webinar. Stephanie, if you could advance to the next slide, please. For any technical questions, please type your question into the questions or chat panels at the lower right of your screen. All telephone lines are muted, and due to the number of attendees on today's webinar, please use the questions panel to ask any questions during the webinar. We will have Q&A following each of today's presentations, and a copy of the slides and the recording of the session will be posted in early January at healthitsafety.org. If you have any general questions about the webinar series or would like other information, you can contact us at healthitsafety@rti.org. Thank you all very much for joining us. I'd like to turn things over to John Wald for opening remarks.
Hi, everyone. This is Jonathan Wald from RTI, and I just wanted to welcome you all to our Health IT Safety webinar series, which is a series of 10 webinars that will be focused on health IT and patient safety issues. We're planning to schedule them monthly through next year, September, and this is the first one. We're working already on the second one for January. The topic for that will be e-prescribing, and the details of that are forthcoming. These webinars are funded by the Office of the National Coordinator for Health IT. They're being conducted by RTI. We are a nonprofit research organization as part of a year-long project to develop a roadmap for Health IT Safety Center under contract with the ONC. If you'd like any additional project information, we have it on the website at www.healthitsafety.org. And with that, I'd like to turn it over to our moderator, Mark Graber from RTI.
Thanks, John. Hi, everybody. I'd like to add my welcome. My name is Mark Graber. I work on patient safety projects at RTI, and it's really a pleasure to be moderating our first roadmap webinar. I'm an internist, and I've had the pleasure of working with a mature EMR for over 15 years now. And I think, like many of you, I love it when it saves me time, and I love the many features that help promote high-quality care, like the alerts and the reminders and graphic displays and differential diagnosis generators. But I also get frustrated when it doesn't do what I want it to do, or I open a 5-page copy-paste note. So in my mind, health information technology really is the best tool we have to help improve quality and safety in healthcare. And I applaud the Office of the National Coordinator for encouraging us to focus on how we can continue improving our EMRs, and that's what these seminars are all about. My thanks to Kaveh Shojania, from whom I borrowed this image, and I'm trying to illustrate here some of the many different approaches that have been used to study HIT-related safety. And at the end of the day, we will need to synthesize the information from each of these different approaches, because each one adds unique information from its own perspective. And what we wanted to do in this first webinar was to pick 2 of these and illustrate how they've been used in research studies looking at HIT safety. We are honored to have with us today 2 of the pioneers in this effort, Bill Morella, representing the Pennsylvania Patient Safety Authority, and Jerry Castro from the Joint Commission. Bill will be discussing how HIT-related safety information forwarded through a PSO can be married with other kinds of data to study the big question of whether advanced EMRs really do or don't improve safety. And in the second presentation, Jerry Castro of the Joint Commission will see how information in the Joint Commission Sentinel event database can identify specific types of HIT-related problems that arise in cases of patient harm. We are planning each presentation to run about 25 minutes, and we'd love to allow 10 to 15 minutes of questions after each presentation for any questions you might have. So please feel free to submit those to us, and we'll try to get through as many as we can. And I'd like to get started. So our first speaker is Bill Morella. Bill wears several hats. At ECRI, he's the Executive Director of PSO Operations and Analytics. And more relevant to today's presentation, he's the Program Director for the Pennsylvania Patient Safety Authority and in charge of the safety surveillance and response systems that monitors the adverse events and close calls in the state, digests all this information and gets it back out to everyone in the form of advisories and summaries. And if you've seen these reports, they are exceptionally well done and are a real role model for how we can all learn from reporting and analyzing patient safety incidents. Bill is widely published in the leading patient safety journals and has served on any number of national projects and advisory committees. Bill, welcome and thank you for being with us today.
Okay, thanks, Mark. Welcome, everybody. I wanted to start off by telling you a little bit about the Pennsylvania Patient Safety Authority, because you may not know of us if you're not from Pennsylvania. So if we can go to the first slide, please. Okay, so Pennsylvania is a little bit unique. It's a state agency that was created in 2002, shortly after the the IOM report to Air is Human in 1999. And in many respects, I think the crafters of the legislation authorizing PSA kind of viewed what they were doing as implementing some of the IOM's recommendations around safety surveillance. So they really wanted us to focus on the mission of reducing medical errors and other forms of adverse events, basically by identifying problems and then going the next step and implementing solutions to actually promote patient safety. And PSA is a little bit unique in that a lot of other states that have similar reporting requirements to Pennsylvania do it under their State Department of Health and under their regulatory agency. And most of those states have focused on a very short list of extremely rare and extremely harmful events. In contrast, Patient Safety Authority gets reports that run the gamut from simply unsafe conditions that don't even reach the patient up to and including very serious adverse events that cause harm or death. We get about 230 to 240,000 reports a year. The vast majority of those are either unsafe conditions or near misses. So it's the minority of events that actually cause harm. But we're up to about 2.25 million reports at this point. And basically what we do with them is analyze those, put the information back out to the community, and in many cases fund and run collaboratives in which we're pulling together institutions that are interested in working on one particular patient safety issue or another, and working collaboratively to figure out how we make those adverse events get better. Can we go to the next slide, please? So what kinds of health IT related events do we see? In 2009, we had the Recovery Act with its financial incentives for hospitals and physician practices to adopt the electronic medical record. And as that happened, we saw more and more events in which the EHR was either mentioned or events in which the EHR may have either played a contributory role or a direct causal role in the adverse event. And our system for surveillance really predated the wide rollout of EHRs, so we don't have a lot of structured ways of capturing that information in our system. It just sort of leaks into the unstructured fields. So what we were finding when we looked into it were some of the kinds of errors that you see here and many others. And we've done a couple of studies that I linked to in the last slide that you can read for more information about what those studies showed. But I'll just, if we can go to the next slide, I'll just give you just sort of a brief synopsis of where we are in terms of our early findings. So normally when you talk about IT problems, people are thinking of the computer itself, they're thinking of the hardware and software, they're thinking of computer crashes and things, and software bugs. But basically in the events that we saw, at least as many, if not more, problems were either happening on the human side of the equation, so there were knowledge deficits on the part of the user, or they were problems at the human-computer interface. There were at least as many of those as there were that were attributable primarily to the IT itself. So I know Jerry will get into more detail about this, but you really have to look at the whole socio-technical system in which these systems and the people who use them are operating. The other main finding is a lot of the problems that we're seeing are very analogous to things that are left over from the paper record that haven't been addressed yet. So, for example, one of the big problems that everyone thought would be addressed by the electronic medical record, and in many cases it is, was getting over the problem of physician handwriting and illegibility. Well, there's a corollary to that in the electronic world, in which it's very easy for people to pick the wrong drug from a pick list. So, before we had the problem mediated through, illegible handwriting, you can still get the wrong drug today, just now it's more likely to happen because, someone picked the wrong drug in a pick list, or they entered the order into the wrong patient's chart. So a lot of those problems still persist from the paper world. In terms of the solutions, I think a lot of us are looking to more robust clinical decision support, and clinical decision support that's more context sensitive. So, for instance, if I've prescribed this drug for this patient 10 times in a row, it's probably not that helpful to keep alerting me that I have to consider a drug interaction when the patient's already tolerated those two drugs in the past. So I think those things are coming, and I think we'll get there. In the meantime, I tend to look at health IT sort of as a double-edged sword, in that it is both the solution to many patient safety problems that may, on their face have nothing to do with health IT. But in the short term, as we're rolling these things out fairly quickly over the past couple of years, many of the implementations that we've seen so far could stand to be significantly improved. If we can go to the next slide, please. I just want to share an anecdote that comes from one of the facilities that we're participating in, the multi-facility collaboratives that I was describing. So we had a project in which we are trying to reduce the incidence of patients getting overdoses of opioid narcotics. And basically when that happens, and the way you can tell that it's happened, is a patient is prescribed a narcotic, and you see the use of Narcan in the chart, and generally this is outside the context of an OR where Narcan's used more frequently. But Narcan's a reversal agent for the narcotic, and what you're worried about when you give too much narcotics is you're going to depress the patient's respiration and potentially get into a code situation. So this one facility that was involved in this project went back to their EHR, and in the course of an afternoon pulled all the recent cases they'd had of patients who were overdosed and given the reversal agent Narcan. And what they found was that the vast majority of patients who got those overdoses were given exactly 4 times the recommended dose for an opioid-naive patient, and most of them were opioid-naive. So you build up tolerance to opioids over time. The more times you get it. So basically, what they found was in their CPOE system, 1 milligram per ml was the default value for people who are entering these orders, and that's the appropriate dose for a patient who is opioid tolerant. He's developed a tolerance for it. If you were just getting it for the first time, the dose you should be getting is 0.25. So basically, simply by changing the default value in their CPOE system, this facility saw a significant and dramatic improvement overnight in terms of the number of overdoses that were occurring. So on the one hand, you can look at this event and say, all right, well, the EHR sort of led the clinicians down the wrong path and created that problem. And that's true. At the same time, this facility in an afternoon was able to diagnose their problem, implement a solution, and check that it was working in a very short period of time. And that those same actions would have taken weeks to do in a paper chart world. So I think EHRs show a lot of promise, and as we work through these short-term implementation problems, I think we'll start to see that pay off. Next slide, please. So I want to switch gears now and tell you about one specific study that we've done, and I want to acknowledge my colleagues Zia Hidari and Rahul Talang, who are econometrics researchers from Carnegie Mellon University. And my name is first on the opening slide only because I'm the one scheduled to give the talk today, but Zia really did the heavy lifting, so I just want to acknowledge that. So when I first talked to Zia about this project, I said, look, I'd love to find a way to mine the Patient Safety Authority's data to answer the question whether EHRs are a net positive or a net negative influence at this point in their development in terms of patient safety. And what's the net effect going to be of the EMR right now? And given the kinds of problems that I've described so far, you could see this going either way. Mark opened with explanations for all the benefits that we expect to get from the EHR, but we also know that there are some unintended consequences that we're seeing. So we didn't really know going in whether there was going to be a net positive or net negative effect. So the way we went about this was we started with the set of all the acute care hospitals in Pennsylvania, and for reasons that I'll get into on the next slide, we had to back off of all of them because not all of them were represented in all of the data sets we wound up using. But we're basically starting with acute care hospitals in Pennsylvania, and we're examining the changes in their reporting patterns between 2005 and 2012. And remember that the financial incentives for EHR adoption started in 2009. So this time period gave us a really nice period in which to look at this effect. The other important thing to note is that we're not just looking at any EMR. We're looking specifically at advanced EMRs. So lots of facilities have a very basic EMR, and in their most rudimentary constructions where they don't even have clinical decision support yet, those are hospitals that are really at an early stage in their adoption. So we wouldn't necessarily expect to see an effect there. Where we do expect to see effects is sort of on the higher order EMRs, where you have CPOE implemented and you're actually getting physician documentation ideally, and I'll get into a little bit later why we did that and did not focus on clinical decision support independently. Next slide, please. Okay, so these are the data sources that we used. We started off with all the adverse events that we get at the Pennsylvania Patient Safety Authority. And for the EMR adoption variable, we basically looked at the HIMSS database, which is not complete. Not every hospital participates in the HIMSS database each year, but they have very good coverage, and it's basically the one that's used in research studies, and it's the best that we have available right now. So we have a number of hospital level controls that we're looking for. So when you talk about trying to isolate the effects of the EHR in particular from all the other things that might influence people's reporting patterns or patient safety, these are some of the other variables that we had to work with in terms of adjusting for these to try to isolate the EHR's effects. And there were some of these are characteristics of the hospitals, like what their inpatient census is, their teaching status, Joint Commission accreditation, adjusted case mix, things like that. And then other things are more global demographics about the economic environment in which those facilities exist. So there we use some population-based variables from the Area Health Resources file from HRSA to get at those county-level controls. Next slide. So in terms of the methods, we used an econometrics approach, or a difference in differences is the other catchword that people use to describe this. And I'll explain this in a little bit more detail on the next slide. But what this approach does is that it looks at each hospital in isolation in sort of, if you can imagine a multiple regression model, each facility is sort of compared to itself independently, and you're looking at each facility sort of before and after their adoption of the advanced EMR as we've defined it. So in statistics terms, this is called a fixed effects model, but basically what it does is that it adjusts for hospitals' reporting culture, which in our view is the thing that probably is most determinative of the volume of reports that we see from individual institutions. I'll talk a little bit more about that in a bit. So the unit of analysis that we're looking at is the hospital year. So in every year, a hospital is either an adopter of the EMR or not. So basically what we're able to do with the HIMSS database is identify the year in which the hospital did adopt the advanced EMR and see what the subsequent effect is on their patient safety reporting. Actually, I'll skip over these controls because I think I discussed those on the previous slide. Can we go to the next one? Okay, so let me try and explain this difference in differences approach because it's not all that commonly used in the healthcare literature. So basically, we can't do a randomized controlled trial of hospitals related to their EHR adoption. We can't decide that certain, and we can't even do a really good controlled study prospectively and say, all right, these hospitals are going to adopt the EMR and these other ones are not. What we can do is look at what they did do, so we can use data retrospectively to analyze what the effect was of EHR adoption. So imagine, if you can, this hypothetical study in which you're looking at two different points in time and on some outcome of interest. So imagine there are two adjoining states, and one state creates a mandate for health plan coverage of nicotine replacement therapy for people who want to quit smoking. And the adjoining state next to it does not have that mandate. So what you could do is look prior to the mandate and look at the utilization rate of nicotine replacement therapy in the one state and compare that to the effects that you see in the other state after the mandate goes into place. So if you're looking at this graph on the screen, the control group, or the lower bar, might, the C1, C2 line, might be the control state, essentially, the one that did not put the mandate in place. Go up a bit, and the line that's labeled E1 to expected difference has the same slope as the line below. So the state that did implement the mandate, you also see an increase in utilization of nicotine replacement therapy there. But if the mandate had any effect, it would actually boost that line so that it would go up to the point labeled E2. And basically what that does is it allows you to control for the idea that perhaps nicotine replacement therapy use is increasing nationally everywhere. So just the fact that it goes up in these two states, that maybe doesn't mean all that much. What you can do is, though, use the control state to adjust for that characteristic of the experimental state, so to speak. Okay, can we go to the next slide? All right, this I just want to comment on quickly, just so that you can see the rate of EMR adoption. And again, we're talking here not about any EMR, but an advanced EMR as we've defined it. And what we see is that in 2005, 40% of the hospitals in Pennsylvania already had an advanced EMR, and by 2012, that percentage creeps up to 75, or 70 rather. So we've seen the EMR adoption we would have probably expected, given the the financial incentives starting to become available in 2009. Next slide. So over this period, you're seeing significant increases in the overall volume of reporting. I don't know if the Patient Safety Authority's database is the largest in the country. It might not be, but it is certainly among the largest. And that volume has generally increased over time. And most of those increases are in the near miss reporting, which that was one of the recommendations the Institute of Medicine made. And I look at the volume of reports that we get as an indicator of buy-in from the facilities that we work with. But this will give you an idea of what the event volume looks like overall. Next slide. All right, so here's the results. Basically what we found was in the years following adoption of the advanced EMR, we see a 27% decline in reported events across all these facilities in the aggregate. So on average, a facility that adopts an advanced EMR sees a significant net benefit in terms of their overall patient safety events. There's a 30% decline in their number of reported medication error volume, and a 25% decline in reported complications. So basically what this slide shows, this is basically showing the residuals after you've adjusted for all the county level controls, the hospital level controls that I've talked about, and you adjust for all those characteristics, what you're left with is an estimate of the effect of the EMR itself. And as far as those things we can adjust for, actually. So basically what you're seeing is that that significant break in the year following advanced EMR adoption. And if you notice, the line on the right basically gets further and further apart from the line on the left. So this is suggesting that basically there's a significant decrease very shortly after EMR implementation, and then that improvement not only persists, but it actually gets even more marked over time. Next slide. Okay, so one of the things that you should be concerned about is that this is not a prospective study and it's not a randomized controlled trial. So there's there's lots of risk when you're talking about looking at correlations, essentially, which is what we're dealing with, and making assumptions about causation from these correlational relationships. So in econometrics, what they do is they do a number of what they call falsification tests or robustness checks to look for evidence that the correlations they're seeing are spurious in one way or another. So one thing that we looked at was whether non-clinical IT adoption explains the difference that we see in people's report volume. So it could be that introduction of any IT, not the EMR necessarily, might be beneficial, and it could be that hospitals who are more likely to adopt the EMR or an advanced EMR might be fundamentally safer than those that don't. So we need to take that into account. But basically what we found is we did not see any effect when we looked at other forms of IT that the hospitals adopt. The other thing that you can look at is what's called reverse causality. So there's sort of an implicit hypothesis in this study saying that adoption of the EMR has some effect, positive or negative, on people's report volume. Well, it could be the other way around. It could be that hospitals with higher incidence of patient safety events might be more inclined to adopt the EMR as a way of preventing those events. But we don't see any evidence of that when we try to redo the analysis that way. The other thing that you can look at is spurious correlations. So it could be that EMR adoption and the volume of patient safety reports are both influenced by some other factor that we haven't thought of or that we're not able to measure. So one thing that we looked at to determine that is whether EMR adoption has any effect on types of patient safety events that are generally not thought to be associated with EMR. So in our case, we looked at skin integrity events, which is a large category of data for us. But what's in that category are things like pressure ulcers, lacerations, burns, skin tears, things like that are much more, if you're going to prevent those, the EMR is probably not going to be your frontline intervention. We're dealing more with nursing care primarily. And basically what we find is we don't see any effect following EMR adoption on the skin integrity category. So we're looking at that as a falsification test. And we also tried a number of other additional controls. For instance, one thing that's significant to PACE, to the Patient Safety Authority, is we have electronic interfaces with a lot of facilities who basically report from their internal risk management information systems directly into our reporting system without any human retyping of events. And facilities that can do that and that establish that interface with us, they generally report a lot more than people who don't have it. So we looked at whether that influenced or falsified our results, and we don't see any effect there either. Okay, next slide, please. Okay, so in terms of limitations, we have to acknowledge that the number of events that people report to the Patient Safety Authority and any other patient safety organization is not necessarily equal and is not equal to the number of events that actually occurs in the real world. We know that every system has underreporting, and there are all sorts of variations in the ways people interpret their reporting requirements, regardless of whether it's mandatory, voluntary, or anything else. The HIMSS database, as I said before, is incomplete. Generally, it varies year to year, but basically they have about 50% coverage of the hospitals in the U.S. in any given year. All EHRs are not the same. So even when you're talking about the same product from the same vendor and even the same version, all EHRs are not the same. The implementation and the choices that the hospitals, in this case, make will influence the effectiveness of the EMR. And so basically that violates the principle of treatment equivalence. If you do a study of a drug, you're giving the same dose of the same drug to everybody. In this case, that's not necessarily true. And even if the EHRs were themselves the same, many differences exist in the implementation. What units it's rolled out to, what the intensity of usage is, whether the physicians are required to use the EHR or not. There are all sorts of variables that could affect the intensity of use and other things that might influence whether or not the EHR had an effect on patient safety. We also couldn't rule out the risk of selection bias, so it could be that facilities that are safer and or more likely to adopt the EHR are more likely to, for instance, participate in the HIMSS database. That's certainly possible. And as I said, the data are observational and retrospective. This is not a prospective RCT, but the way I interpret this is that I sort of take a best evidence mindset, and given that you can't do an RCT to answer this question, I think this is the next best evidence available for the moment. Okay, next slide, please. So I'll wrap up by just stating again, I think these data suggest that advanced EHRs are generally a net safety benefit, but these results are definitely in the aggregate. So while I gave you the average results that we saw across this whole population, not every facility necessarily got those results. Some did better, some did worse. I also want to just restate that we are seeing a lot of unexpected problems, and those should continue to be identified and addressed locally. And I do feel that clinicians' concerns about the EHR usability, things like alert fatigue, and Jerry will talk a lot more about this side of things, but I think we have to acknowledge those and acknowledge the validity of those concerns, and those also have a safety effect. The other point that I would make in conclusion is that the implementation is never over. So once the EHR is put in place, the next phase that we all need to get into now that we've got this infrastructure in place is to optimize the infrastructure, and that means making the clinical decision support more robust, making the our use of the EHR safer, and really integrating this with our other efforts to make American healthcare system more highly reliable. So I'll end with that and turn things back over to Mark and ask if there are any questions.
Hi, Bill. That was terrific. A very interesting and unique study, and I think we'll start seeing many more studies that use that kind of approach. There are questions coming in. I'd like to throw some of them at you. There are questions about the HIT-related events that get reported into the Patient Safety Authority database. This is a question from Alice Weiss. Could you describe in a little bit more detail how the event reporting system works?
Sure. So, well, again, we're talking about the hospital environment in particular in this study. Patient Safety Authority also gets events from other settings, but primarily they're coming from hospitals. And most hospitals at this point have internal risk management information systems. So for most of the events that get to our system, they're coming through an electronic interface from those internal systems. So basically, an event starts with a nurse or a physician or a pharmacist recognizing a problem that they want to report or recognizing a patient safety issue that needs attention, and they'll report that in their internal risk management information system. That feeds up to, in some cases, those reports will be routed to unit managers or department managers, and eventually we'll get up to a patient safety officer. And that patient safety officer is responsible for getting the events from their institution to the patient safety authority. And the vast majority of them are coming electronically at this point, though there are a large number of facilities that either can't afford or haven't chosen to invest in an internal risk management information system, and they use our system basically as their main reporting system and their main repository for patient safety data. So a lot of them, and this is generally smaller community hospitals, are using our system directly, and they enter reports one by one into our system over the web.
Great, thanks, Bill. Another follow-up question. This is from Tobias Samo. You mentioned that you're getting almost 250,000 reports annually. Do you have an idea what fraction of those are HIT related?
Hi, Toby. Good to hear from you. I don't have that. I don't have that statistic off the top of my head. What I can say is a lot of the events that we see that in which the EHR is mentioned, they're not necessarily all EHR related. So sometimes people are reporting things and they're just they're saying that Mrs. Smith fell and I documented that in the EMR. All right, so that's not really a case about the EMR. Conversely, you also have the situation where people are reporting a medication error and they're coding it in our system as a medication error, and they don't necessarily mention any health IT system associated with that. But when you read the event, you can sort of surmise that if we know that facility has an EMR, we can look at that in a different way. And if you've got good clinical decision support and you've got an advanced EMR and you're still seeing a lot of medication errors, lab errors, errors in radiology, I mean, those are really the categories in which the health IT associated events occur most frequently.
Thanks, Bill. One more question on the database. To what extent do you think the reports coming in under-reflect or over-reflect certain types of HIT-related events?
Well, the problem of under-reporting is not unique to health IT events. That's really kind of a characteristic of these systems, is that they, honestly, any of you who have had relatives or yourself been in the hospital would probably know that you can't possibly report every adverse event and every near miss that could conceivably be reported. So I always kind of start looking at these systems with the expectation of under-reporting. One of the things that I really like about the approach that we took was that we're essentially adjusting for hospital reporting culture. And so, for example, when we've looked at hospitals that are similar in size and similar geography and similar type of hospital, and we look at the volume of reports they submit per 1,000 patient days across the board of every type of event, there can still be 40-fold differences in people's report volume. And I definitely don't think that there are 40-fold differences in the safety of healthcare delivered at different institutions. So I definitely attribute that to people's reporting culture. Some places are just more vigilant about this than others, or they have different interpretations of what's reportable. What I like about the approach that we've taken is that we've essentially adjusted for the hospital reporting culture by using this fixed effects model in which each hospital's reporting is compared to itself, after EMR adoption. So while I do acknowledge that the reports don't equal the number of events that actually occur, I think we've adjusted for that as best as we can at this point.
Yeah, that's interesting. Thanks, Phil. Good point. A couple questions about the results of your study. You mentioned that EMR adopting an advanced EMR cut down on the total number of events reported. Did you look in more detail to see if it affected certain types of HIT events more than others, or certain types of other patient safety events?
Well, yeah, basically what we saw was, we saw significant declines in the overall level of events, and we saw declines in medication errors and complications. So, and we did not see significant declines in other top-level event types, like skin integrity was one of the other ones that I talked about. Which makes sense if you think about how people are using the EMR. The thing you're using it for most is entering orders, the vast majority of which are either for procedures that could result in complications, or or drug orders. So so those were the event types that were most significantly affected.
Great, thanks. This is a question about being able to isolate the effect of adopting the advanced EHR. So organizations with advanced EHRs might have more resources or better safety cultures. You think these factors may have been playing a role in explaining some part of the results?
Certainly, I would expect that they would have an influence, sure. And I don't think anything that we did would have explicitly addressed, whether some of those hospitals at the beginning were safer than others necessarily, but in terms of their economic resources and how sophisticated are these hospitals, are teaching hospitals more sophisticated than non-teaching hospitals? A lot of those hospital characteristics we did adjust for explicitly, and in terms of economics, those were really adjusted for at the county level. So basically, hospitals situated in more affluent counties, we would have adjusted for that.
Great, thanks. I love the example you gave about the default dose for choosing the opiate, and what a wonderful lesson that was. How do you get that kind of lesson distributed to the other organizations besides the one where the error occurred?
Webinars, for one thing. So basically what we do is we have layers of responses to things like this. So the main way we distribute sort of our research findings is through our patient safety advisory, which that's on our website, and it's very, very widely distributed throughout Pennsylvania, and we have people all over the country and the world that subscribe to it. Anybody can join our mailing list and get that if you like. So that's sort of like the global communications vehicle. We do a lot of education in the area of tens of thousands of people a year through venues like this, and webinars that we put on by ourselves. We also have something that's kind of unique, which is a patient safety liaison program in which we have representatives from the Patient Safety Authority who are assigned to every acute care facility in the state, and they interact with those facilities daily, and make a point of visiting them once or twice a year. So generally what we're doing is when we find somebody who has a particular need or a particular problem, sometimes we're identifying them through the data that they're reporting to us. We're able to put them in touch with other facilities that have addressed that problem. So it's almost like a mentoring type approach. We also are able in our data to figure out when people have had problems that they've addressed. We engage them and make them part of our team in terms of communicating those messages to others. So many of the facility collaboratives that we've done in partnership with our member hospitals who help us implement the project.
Great, thanks, Bill. We have time for just one more question, and I'd like to relate one that was given to us by Gregory Berger. I'm just going to summarize it. How are we working with IT vendors to address issues identified within their products?
Actually, the Patient Safety Authority has has not worked with the vendors directly. And it's not like we're California, like we're our own economy and have that wield that kind of market power. But we are putting out this information in the public domain and doing what we can to disseminate these results. We've done a number of speaking engagements and published things on behalf of ONC. So we're trying to get the information out in that way.
Great. Bill, that was a fantastic presentation, and we really appreciate your being with us today. Thanks.
Thank you.
I'd like to transition to our second speaker, Jerry Castro. Dr. Castro is the Project Director for Patient Safety Initiatives in the Office of Patient Safety at the Joint Commission. He has primary responsibility for the Joint Commission Sentinel event database and manages the coordination, the reporting, and the tracking of all the Sentinel events and complaints and other patient safety initiatives in the Division of Healthcare Improvement. Dr. Castro is also the principal investigator for the ONC's Health IT project investigations of health IT-related deaths, serious injuries, or unsafe conditions. He administers the Patient Safety Advisory Group, which advises the Joint Commission on high priority and emerging patient safety issues. He is also a member of the NQF Common Formats and HIT Patient Safety and Expert Panels, as well as the HTSI Coalition of Organizations for Reporting Adverse Events Committee. Jerry, welcome. Thanks for being with us, and we're looking forward to your presentation.
Great. Thanks so much for this opportunity to speak to you all today. So as Mark mentioned, I will be presenting the findings, some of the findings from our ONC-funded project, Investigations of Health IT-Related Deaths, Serious Injuries, or Unsafe Conditions. Next slide, please. But first, I'd like to acknowledge that this project was funded through a contract from the Office of the National Coordinator for Health Information Technology, and also acknowledge the efforts of our project officer, Kathy Kenyon, especially for her guidance and support. Next slide, please. So the project consisted of an analysis of Sentinel events to determine if Health IT played a role in the Sentinel event, and if so, how. We also performed learning visits to 4 accredited medical centers that focused primarily on how their health IT systems were organized and structured, how well they function, and to describe any risks or unintended consequences associated with their use of health IT. So I would also like to go over some of the process associated with our reporting of Sentinel events and some of the limitations of that data. I'll also go through our analysis of the different Sentinel events and then go over the results, and then of course share some of the themes from the learning visits we performed at the 4 accredited medical centers. Next slide, please. So the slide here describes what a reviewable Sentinel event is, and I think the major takeaway here is that Sentinel events resulted in an unanticipated death or major permanent loss of function. So those are very important terms because what these types of events represent is the very high harm and rare type of safety event. Sentinel events are voluntarily reported to the Joint Commission, so they don't represent the incidence nor prevalence of these types of events. So as Bill mentioned in his presentation, there is a lot of variability in safety event reporting, and so a lot of those limitations apply here. Next slide, please. So our policy also specifies that there are certain other event types that may not necessarily have resulted in the death or permanent loss of function to the patient, such as the third one on the list is abduction of any patient receiving care, or the fourth one is discharge of an infant to the wrong family. So those might not necessarily have resulted in harm, but these are different types of events which require a in-depth type of analysis. And the preferred method, or the method that we recommend, is of course the root cause analysis. But as I mentioned before, as you can see from both of these slides, in general, these are the high harm, rare safety events that we get in our database. So the next slide, please. This particular slide gives you the iceberg depiction of patient safety events. And so what I show here is that the reviewable Sentinel events, or the events that we actually receive and we analyzed here, represent the very tip of that patient safety event iceberg. So if you're unfamiliar with this analogy, Everything above the waterline are the adverse events that have reached the patient and have caused harm. Underneath the waterline are those events that we may or may not see. So those are the no harm incidents, the near misses, and the hazards and risks. Again, these are the rare events. And so in general, we receive approximately 1,000 reported sentinel events per year. So it's a different kind of volume compared to, as Bill mentioned, the Pennsylvania system, where they receive up to 200,000 or more. Next slide, please. So next I want to describe a little bit about the process for which sentinel events are reported to the Joint Commission. So we will receive reports of sentinel events via the organizations themselves, through a phone call, through electronic submissions through our website, paper submissions of a report, or even complaints. And so complaints can include media reports of an event, or letters from patients or complaints from patients about a family member, or even from individuals who are employed by the organizations. Those can show up as complaints as well. And then the final mechanism for us receiving sentinel event reports is from surveyors that are actually on site. So what happens is, once these reports come to our office, a patient safety specialist, which is in general either a master prepared nurse or a human factors engineer, will review this event or the report with the representative from the organization. So that's where it says call with the organization. The two boxes, I believe they're light blue on the either side of the yellow diamond there. And so it will be a discussion with that organization to determine, is this a so-called reviewable sentinel event? And if it does meet that criteria of reviewable sentinel event, which was described in the past few slides, our patient safety specialist will work with that organization to review their root cause analysis of the event, and they'll work to ensure that the analysis they performed of the event was thorough and credible. And we have specific criteria for those defined in our sentinel event policy. Once those criteria are met, then the root cause analysis and the plan of action are accepted by our patient safety specialist, and then the information is abstracted into our sentinel event database. Well, I should say it's de-identified and saved in our sentinel event database. Next slide, please. So the types of data that we have within our database are both categorical and narrative. So you'll see we have just general information about the patient, the outcome of the event, where the event occurred, the type of event that occurred, and some of the causative factors associated. And we have a large classifications of the different causative factors there, but none of them necessarily were specific to health IT, and so I'll speak to that in a moment. We also have narrative data, which includes the summary of the incident, whether that be if it was, for example, a media report, we would have a copy of the media article, or if it was a complaint, we would have a copy of the complaint. So that would be the summary, and then we would also have access to the patient safety specialist synopsis. So that's basically a paragraph or two describing in total what happened during the course of the event, who was involved, and ultimately what were some of the causative factors. And then finally, we also have the organization responses to the RCA framework questions, which I'll describe in the next few slides. Next slide, please. So the RCA framework is composed of 24 different questions, and this is available on our website if you're not familiar with the RCA framework. But I will point out that the RCA framework is intended not to be an RCA. So if you answer all of these questions, this is not an RCA. these are just some questions or prompts to ensure that you, if you're doing an analysis, that you have gone through all of the different factors and considered the different dimensions of the particular event. So in the case of our analysis, on this, of the first 8 questions, the first 4 questions were particularly valuable. So what was the intended process flow? Were there any steps in the process that did not occur as intended? And then number 3 especially, what human factors were related to the outcome? And this will come into play in a moment. And then number 4, how did the equipment performance affect the outcome? Next slide, please. Oh, okay, there we go. So these are questions 9 through 16. And in this particular slide, questions 13 through 15 were particularly helpful in our analysis. Those questions deal with the staff performance, and then it also dealt with the degree of availability of information and then the degree of communication. So next slide, please. There we go. And so these are the final 8 questions. And so in this set of questions here, the last 2 questions were particularly valuable in our analysis. Was available technology used as intended? And then how might technology be introduced or redesigned to reduce risk in the future? So this is where we really get into some of the technology-related issues and where the analysis starts to get into that. And now I will say, as part of the categorical information, and I alluded to this before, we don't have specific categories or event types for health IT related events. So health IT related events were uncovered during the course of us looking through the analysis and reading through the different narratives. So none of the events that we looked at were originally categorized as health IT related events. Next slide, please. So the sample that we used was sentinel events reported to the Joint Commission from January 1st, 2010 to June 30th, 2013, and that represents 3,375 sentinel events. We used a two-step process in analyzing the sample, where we used electronic database queries. We used the categories and then a keyword search, and then finally the content analysis, where 2 master prepared nurses and myself, we individually reviewed the analyses and tried to determine whether or not health IT was involved, and if so, how. Next slide, please. So this slide shows how we started to dig deeper and dig down into the database here. So from 3,375 sentinel events, after the categorical and keyword queries, we came up with 195 potentially health IT related sentinel events. So as Bill mentioned, we could come up with events that where somebody might enter the information. The medication was entered in the EMR, right? And so that would be flagged as a potential health IT related sentinel event. But after the content analysis, we find, well, it didn't really play a role. And so we were pretty stringent in determining whether or not health IT actually played a role. There were some events where we suspected it did, but if they did not explicitly say within their analysis that it did play a role, we excluded it from consideration. So we ultimately ended up with 120 health IT related sentinel events. Next slide, please. So of those 120 health IT related sentinel events, the top 3 event types were medication error, wrong site surgery, which includes wrong side, wrong procedure, or wrong patient, and then delays in treatment. Now, interestingly, suicide and falls were the 4th and 5th most frequently health IT related sentinel events, and that was because those types of events dealt with the clinical decision support or the risk assessment for suicides or falls respectively, and the clinical decision support did not was not up to date, or it did not behave as the user expected to, or it should have triggered off the decision support when it in fact did not occur. Next slide, please. So what we did is we created a classification for the different contributing and causal factors. And what we did is we used Dean Sittig's and Hardeep Singh's 8 dimensions of the health IT socio-technical model as the high-level classes. So the different contributing factors. We also scan the literature for other contributing factors or different from the ARC common formats, the ARC hazard manager ontology, and then Farah Maghrabi's classification of health IT contributing factors. And so what we did is we took those different types of contributing factors and then we put them under the 8 different dimensions of the socio-technical model you see here in front of you. So the different contributing factors, and if you're unfamiliar with the socio-technical model, I'll briefly describe the 8 different dimensions here. So hardware and software included computers, keyboards, data storage, software to run health IT applications, and this included the system-to-system interfaces between the software components. The clinical content, number 2, is the data, information, and knowledge stored in the system. So we're talking about the such as the risk assessment for the falls or for suicide. That speaks directly to the clinical content. The human-computer interface, as Bill mentioned, was where the person will actually interface with the technology. So that's the hardware and software interfaces that allow the user to interact with the system. Number 4 is, of course, the people. This will include the software developers, IT department, personnel, clinicians, staff, patients, and others involved in health IT development, implementation, and use. Number 5 deals with the workflow and communication. So I think that's actually pretty self-explanatory. But number 6 deals with the internal organizational policies, procedures, environment, and culture. And so these are the internal organizational factors, and they can include such things as capital budgets, IT policies, event reporting systems, and any of those types of things which will affect aspects of health IT development, implementation, use. The number 7 are the external rules, regulations, and pressures. Those are the external forces, such as federal and state rules, to ensure privacy and security protections, and then also federal payment incentives that spur health IT adoption. And finally, number 8, system measurement and monitoring. And so those are the processes to measure and monitor health IT features and functions. So next slide, please. So of the 120 sentinel events we identified 305 contributing and causal factors. So those numbers are different because each event will have multiple contributing and causal factors. And so when we categorize them according to the socio-technical dimensions here, we found that most of them were associated with the user interface. We see 33%. Secondly, were workflow and communication issues at 24%. And then at 23%, we had clinical content issues. And then on down the line, and everything else to a lesser extent. Next slide, please. When we organize these by the most frequently related, most frequently identified contributing factors, we find that communication issues were the most frequently identified at 37, and data entry or selection problems were second. Clinical content issues were third, and then so on down the list. So these were just the absolute number of times that these problems were identified as contributing factors. But when we look at these by the specific socio-technical dimensions, which we'll do in the next slide, please, we see the breakdown in even more detail. So of those contributing factors associated with the human-computer interface, this is the breakdown that you're looking at here. So 101 contributing factors were associated with the human-computer interface. And so we see a lot of them deals with the way that the interface, with data entry or selection. So as Bill mentioned, having to go through a pick list that could have defaulted to the wrong value, that kind of thing. Secondly, the second most identified contributing factor was that the information was hard to find. So you can imagine yourself navigating through an EMR and trying to find a piece of information, but it's not located in this system, it's located in this system. So I have to log out of this system, log into this system. So there were a lot of those issues as well. There were some information display or interpretation issues. So the size of the display didn't accommodate the resolution, so it was difficult to see particular bits of information. And then unexpected software design issues. So, and then down the line there. Next slide, please. So workflow and communication contributing factors were the next dimension that was more frequently identified, and those represent 72 different 72 contributing factors. And of those, it was primarily communication. And then, so we talk about the workflow and the ability of the technology to support that communication among the team members. So, well, one of the incidents we see is that when a clinician charts the information, and then another clinician does not have access to that piece of information because they are a different type of clinician. Okay, so that's a broad generalization, but it's a problem that is seen frequently enough, and this is an example of the communication, suboptimal actual communication among team members, and then also suboptimal support of teamwork. So that's an associated contributing factor. And then mismatch between user mental models, expectations, and health IT. So the expectation that, I'm going to chart this information and that this piece of information is going to get from point A to point B. That was actually a particular issue associated with, I would say, the wrong site surgeries, where the scheduling system, a piece of information in the scheduling system was put in the notes. And especially with dealing with either the laterality or the type of procedure, that kind of thing, and it didn't reach the procedure room or the operating room. So those are those types of issues. Next slide, please. Oh, and I should also mention with the previous slide that also those types of issues were associated with hybrid workflows, both paper and electronic workflows. Now this slide describes the clinical content contributing factors, which was the third most identified dimension from the socio-technical model, and with 70 different contributing factors. And as I mentioned before, this primarily dealt with the clinical decision support systems, where clinicians and users expected it to behave in a certain way and it didn't, or the information contained within was not current or up to date. So a patient with a certain number of risk factors should have fired off an alert to do some sort of assessment, but it didn't. And so those are the types of events that we saw associated with these contributing factors. Next slide, please. And finally, we classified the 120 Sentinel events by the different health IT device categories. And this is adapted from the ARC common format. And so in the ARC common format, EHR is considered a category, or in addition to the component of the EHR. So what we did is we grouped those together and then also broke those down by specific components where it was noted. sometimes it's not noted in the analysis itself, and so in that case we just had to put it in the general EHR bucket sometimes. So you'll see the breakdown, and I wouldn't necessarily say that, well, these types of systems have more problems than another. It's just what we saw in our snapshot of different events. Next slide, please. But a theme that it was recurrent through each of these events was that the failures were multiple, and the failures and vulnerabilities were multiple. So those of you that are familiar with James Reason's Swiss cheese model, it's an analogy that represents the trajectory of a patient safety event that reaches the patient. Okay, so you start on the right-hand side of the slide where it starts out as a hazard or a vulnerability, and what it does is it penetrates the defenses. So the first slice of Swiss cheese might represent the EMR, the scheduling system. The second slice is the EMR, and then the last slice of Swiss cheese might be the timeout as part of the universal protocol. In each of these cases, the event that we studied penetrated each of these different defenses and then resulted in that wrong site surgery. So in the case of a medication error, the medication was ordered in the CPOE system. The pick list was designed in a way that it defaulted to the wrong value, and that piece of information could have been caught at the last slice of Swiss cheese using the medication double check, but it wasn't. The medication double check was not performed, and which resulted in the medication error. So in each of the events that we studied, this depiction of patient safety events was true. It started out as a vulnerability distal to the patient, with the health IT, the technology operating in a way that allowed the event to happen. And then, of course, at the sharp end, it was the clinicians not either doing the medication double check or the universal protocol correctly. Next slide, please. So let me transition to some of the findings from our learning visits. So as I mentioned before, we visited 4 accredited medical centers, and we sought to see, how did they implement their health IT system? What were some of the factors that led to their success, and with success with implementation as well as use and continued use. So as Bill mentioned in his presentation, the implementation is never over. So, and what we found is that these organizations were well functioning because that's the type of attitude that they took. Their health IT was very integrated. Their IT staff worked well with their biomedical engineering staff, and they worked well with their patient safety staff, and they got the vendors involved as well when they uncovered an issue. So that was the one factor that I saw in common as far as really what made these organizations successful. The IT and biomedical engineering folks, they got patient safety. They understood what was going on. They understood the value of uncovering vulnerabilities and then reporting those, and then saying, this could have led to a medication error, or this could have led to a wrong site surgery, that kind of thing. So they understood the connection between the vulnerabilities and the technology and to the ultimately reaching the patient and what that all meant. And so they worked to detect those things constantly. And so when Bill said implementation is never over, it's a constant looking at the system and monitoring the system and seeing what are those vulnerabilities. Now, one of the specific problems that some of the organizations talked about is the loss of clinical context. And so that's what I like to characterize as what is going on with this patient. because the information they felt it was removed from the patients, or they're getting bits and pieces of the information from the EMR and not the entire clinical picture of what's going on with the patient. One of my favorite quotes from one of our organizations was, "Documentation is not communication." So just the fact that the nurse documents this in her clinical notes does not mean that that information is actually transmitted to, say, the physician or the pharmacist. So, and sometimes they, and this was from one of the informaticists, they said, and sometimes that's the case. They feel that once I've documented it, it's communicated, and so what they've done is they've instituted a policy of soft handoffs, but that's a different issue. The fourth point there is health IT changing workflow. So as Mark said it in his beginning remarks, health IT doesn't always do what I want it to do, right? And so we as people, what we'll do is we'll change our workflow to accommodate that limitation, when really it should be the health IT should be supporting our workflow and processes, that kind of thing. And then finally, the relevant clinical information was sometimes difficult to find. And so, as I mentioned before, we might find ourselves in the occasion where, well, we need to log into this system for this piece of information. We need to go here for this piece of information. And so it just took time to find out that relevant bit of clinical information. And then we also, one of the other factors that they talked about was the electronic external, when external records were transferred to their organizations, it's sometimes as just scanned documents. And so as we know, scanned documents, it's sometimes difficult to find a particular piece of information, especially when there are so many, there's a volume, large volume of pages that are not necessarily text searchable. So they found that a limitation. Even though they have that information, it was still very difficult to find some information. So next slide, please. So in conclusion, the findings from our sentinel event analysis, they suggest that we work on optimizing the human-computer interface, and that's either through design or uncovering those different vulnerabilities and trying to see what we can do to mitigate those problems, and then of course matching the technology with the workflow. And those are some of the more relevant themes that we seem to be coming up with, both in our analysis of sentinel events and then of course talking with those organizations. So in the future, what we hope to do is release, well, in the near future, we hope to release an e-learning module based on some of our findings, and of course on the findings of the previous research, and then based also on the safer guidelines that are available through ONC. We'd like to publish these findings in the peer review literature as well. And then what we're also doing is considering this as a topic for a sentinel event alert. So as Bill mentioned, the Pennsylvania Authority puts out patient safety advisories. We similarly put out sentinel event alerts, and that's how we try and share these findings with organizations. So that's it. Next slide, please. There we go. So I'll take any questions.
Jerry, this is Mark. That was really interesting data and an excellent presentation. Thank you. I have a couple of questions coming in, and we have about 10 minutes left. A couple of questions about the event types that get reported. The Joint Commission Sentinel event database is really unique. Do you think there's any types of HIT-related events that might be overrepresented or underrepresented given the type of collection that you have?
Absolutely, absolutely. And since, as you mentioned, the sentinel events we receive, it's a unique data set. So if you look to other published reports on other types of safety event reporting systems, such as there was a paper by Derek Meeks with Hardeep Singh and Dean Siddig, where they looked at the VA Patient Safety Informatics database. And so those were focused primarily on health IT or device-related events. Whereas ours will be more clinical focused. And so, some of the events that we found were the ones that were found by virtue of those doing the analysis, and these were primarily clinicians. Versus a patient safety informatics database, they might have more of a skew towards technical side. So they'll find more of the system-to-system interface problems, those things. Which we didn't actually find in our study. We only found maybe one or two of those.
Thanks, Jerry. This one's from Elizabeth Rose. Did you identify any instances where system testing in advance would have prevented the events?
Yes, there were some incidents where that was the case. They had there was an unfortunate, in those incidents there was a go live, which was, I'd say, not well, or there was a situation that was not thought of, and it had to do with a shift change, and from the day shift to the night shift, that kind of thing, and what happens when certain sets of individuals are not there during the night shift, and where does that communication go? So yes, absolutely, some of the testing would have helped prevent those events.
There's two questions about the communication errors that you identified. I'd like to ask them both at the same time, and then you can respond. One question is from Jorge Ferrer. He said, did the documentation effort required for data entry contribute to the communication breakdowns amongst clinicians? And the second question is from Jennifer Thate. Have you been able to separate out the communication-related events due to the EMR?
Both great questions. And so within our the analysis of sentinel events, we didn't find anything related to the documentation burden associated with the EMRs. But during the course of our conversations in the learning visits, that was definitely an issue, leading to delays in treatments, and just the fact that they have to do the hunt and peck to find relevant information. That was definitely an issue for many of those organizations. Now the other question related to communication, as far as
did documentation barriers contribute to the communication breakdowns?
I didn't find that specifically. Only in the sense that some clinicians would document in certain modules of the system, and that piece of information would not be available to other clinicians. That's the extent of those kinds of documentation issues we found.
Okay, this one's from Emily Patterson. Hi, Emily. I was thinking about the same thing. Jerry, did you encounter instances of copy-paste problems or copy-forward problems?
Hi, Emily. Yes, we did. And so, yes, it was definitely we found those instances. There weren't too many of them, but when they did occur, it's just carrying forward inaccurate information, and really that's the crux of all of these issues. It's the integrity of the information is compromised in some way. It's either the inaccurate information is transferred forward, or somewhere along the way it's just not received.
Thanks, Jerry. This question is from Rick Hampton. Given the emphasis of IT and biomedical engineering working closely together, has the Joint Commission considered emphasizing using a patient safety risk management approach, such as the one outlined by the IEC standard 8001-1?
Yes, that is something we are definitely recommending, especially as with the proliferation of technology within our organizations. It's essential. To the extent that IT folks and our biomedical folks are inculcated in patient safety and to understand that and to be involved in those discussions and analysis. That is something we will definitely be promoting.
Gary, this question is for me. You showed us some data on the different kinds of event types, lots of medication errors, wrong site surgery, suicides and falls. Those were the top 4 categories. I didn't see very many cases of diagnostic error in there, which we know are pretty common and which not infrequently involve HIT problems. Any thoughts on why there were so few of these diagnostic error cases?
Absolutely, and it's because we don't have a specific event type. It would be embedded as part of the analysis within the causative factors, that kind of thing. So we didn't specifically look into that area, but I'm just given what we've read about and what we've learned, it certainly would have contributed to those types of errors. Especially when we talk about, the relevant piece of clinical information is not available at the time that the diagnosis is made, and that's something that we did see.
Great. Well, this kind of brings to a conclusion our presentations. I'd really like to thank our speakers. Bill and Jerry both did a terrific job. I'd like to thank everyone for listening and everyone who submitted questions. I'm sorry we couldn't get to all of them. I'll pass the ones that we didn't answer along to the respective speakers. And at this point, I'd like to hand it back to John Wald for some concluding comments.
Great. Thank you, Mark. This is Jonathan Wald. Just wrapping up, I wanted to share a couple of things. One is that a number of people have asked about slides and audio. If you go to the website, which is called www.healthitsafety.org, and then from there /education. That'll take you to a page that will allow you to download or listen to the slides with audio. Those will be available by January 5th. And that page will also be a place where we will be listing the other webinars in the series. As I mentioned, we're working on the second one. It's almost confirmed, but we're anticipating it at the end of January on e-prescribing. Anybody who registered for this webinar and answered the question yes, that they'd like to hear about others, will receive a notice when we have the next webinar scheduled. And there was a question I saw that I can answer quickly. Someone said, what again was Dr. Castro's project with the ONC? And I think, let me just see if I have it here. It's kind of small font. It looks like ONC, Health IT, investigations of Health IT-related deaths, serious injuries, or unsafe conditions. That's what I'm reading off of here. So wishing everybody wonderful holidays and a very nice new year, and we look forward to reconvening on this series in January. And thanks to the speakers, Bill and Jerry, and also to Mark and everybody else for putting this on. Take care, everybody. Bye-bye.